Hello, this is Dr. Robert Keller from Northern Arizona University. We're going to be discussing respiratory diseases in this lecture. This is a part 2 of 2 series. Part 1, we really introduced the space, the field. I talked a little bit about the normal physiology and covered obstructive pulmonary diseases. And so now we're going to focus on the restrictive pulmonary disorders. So what are they? Well, they are a disease that affects and reduces the expansion of lung capacity. So you influence lung capacity, you reduce it, you prevent the lung from being able to expand appropriately. Expiratory volume is either normal or proportionately reduced. So here patients actually can't inhale as much as an uninfected individual or a normal individual. So it's an inhalation problem with restriction, whereas before we're looking at exhalation being problematic for obstructive. So here chest wall disorders can actually play a major role. Obesity, patients that are obese could have problem with inhalation. Pleural diseases of various sorts can influence the restrictive nature or introduce restrictive nature of a pulmonary disorder. So we'll look at specifically some interstitial, some infiltrative diseases like acute respiratory distress syndrome or ARDS as we look at later in the lecture. Again, for your review is a schematic diagram here on this slide. It's characterizing total lung capacity, vital capacity, inspiratory reserve volume, expiratory reserve volume, the residual volume that's left in that dark green towards the bottom of the slide that we didn't touch on earlier at about 1,200 milliliters, and then hovering in between inspiratory reserve volume and expiratory reserve volume is our tidal volume. So just keep this in mind as we talk about some of these diseases, looking at restrictive diseases specifically. So what are their characteristics? General categories, there's chest wall disorders like we had mentioned with obesity. There could be a fibrotic response that's taking place. We could have acute or chronic interstitial or infiltrated diseases like we mentioned previously, acute respiratory distress syndrome or ARDS. In this trichrome stain, so this is a trichrome stain, tri meaning 3 different colors, what we're being able to see or visualize, what we can appreciate from this image, is the collagenous connective tissue in blue that really shouldn't be there. So that's indicative of pulmonary fibrosis. All of the blue throughout this trichrome image is collagen tissue that is there because of a fibrotic response, and it shouldn't be there in a normal lung. Leads to the question of acute respiratory distress syndrome, or ARDS. Well, what is that? What is it? It is otherwise known as, or AKA, it's called lung shock. It will lead to diffuse alveolar damage, or abbreviated DAD. It's also called traumatic wet lung, and it can be rapidly coming on. It could be life-threatening, lead to respiratory insufficiency, and most of that is because of the damage that's occurring to the alveolus or the alveoli. Neutrophils have a major role in this ARDS syndrome. It was a major cause of death among injured soldiers in the Vietnam War. That's the reason for this image on the slide. In the 1980s, the mortality rate was about 50 to 60%. So if you actually had ARDS, there was greater than 50% chance that you're going to die from it. Now it's about 35%. So we've gotten much better at catching it early. We have better treatments. We understand better about the pathology and what's going on. The key to the damage is that there's a massive inflammatory response by the lungs. This inflammation, as you remember back and flash back to our lecture in the beginning of the semester on wound healing and the inflammatory process, we know that in massive inflammation, if you have an inflammatory response in the lung, you're going to see neutrophil infusion early on. The first cells that respond are the neutrophils. What are the next cells that show up? Those would be macrophages. So early on, it's neutrophils. Secondarily, it's macrophages. Just trying to recall your memory from earlier in the semester. These neutrophils can release many different proteolytic enzymes, free radicals, prostaglandins, leukotrienes, platelet activating factor. And now you've got a whole host, a whole cocktail of growth factors and cytokines because of this inflammatory process that the neutrophils are introducing. And that's actually what's causing some of these problems with the lung tissue. What causes it? So we already knew that there's either indirect or direct injury to the lung. And we talked directly, these are slightly out of order. We're going to talk about the bottom list first. Direct injury, diffuse pulmonary infections, SARS can cause diffuse alveolar damage, DAD, DAD. This SARS is severe acute respiratory syndrome. And another situation is gastric contents on aspiration. If the patient is actually under bed rest and they have sort of a GERD or an acid reflux, those contents could come in and cause some damage within or inflammation within the lungs, stimulate an ARDS type of process from taking place. A near drowning. These patients that inhale a tremendous amount of water, there's residual fluid in the lungs, that can cause an irritation or an inflammation response. Chemical injury, mechanically induced, even a respirator. If the respirator isn't set correctly and the pressures are off, you can actually overinflate those alveoli and cause actual minor damage or microscopic damage, and that can induce an inflammatory response. Okay. So if we look specifically at SARS here, this severe or sudden acute respiratory syndrome, it can happen with an infection, and one odd type of infection is called a coronavirus, coronavirus. And this actually comes or is transmitted from a masked palm civet, which is the upper image. This is a civet found in China, and this was prevalent in the year 2002. And these people were actually using this as a food supply, and these civets were actually infested with this coronavirus, which is shown on the bottom image. And the pathophysiology is not well understood, but this virus actually can lead to acute respiratory syndrome, or SARS, severe acute respiratory syndrome. So we know that from direct injury, this entire list at the bottom of the slide can induce an ARDS type of response. Top of the slide, indirect injury, septic shock, the patient goes into shock. They're in trauma, or they're severely burned throughout their body, obviously a shock situation as well. Why? Because of shock? Well, in shock situations, it's systemic. It's affecting all the different systems of the body, including the respiratory system, and you're going to have tissue edema. That fluid that presents there is an indirect pathway because it's not because of a near drowning or aspiration into the lungs, but because of the tissue edema due to shock. Now you actually have injury to the lung tissue that could lead into a ARDS type of scenario. What are the symptoms? So we have a whole list. Again, back to our first slide of this lecture, a lot of clinical terms: dyspnea, shortness of breath, tachypnea, rapid breathing, cyanosis, appearance or blue-purple coloration of the skin or the mucous membranes because the tissues near the skin surface are low on oxygenation. Hypoxemia, decreased partial pressure of oxygen in the blood. Specifically, sometimes it's less than 60 millimeters of mercury. That's usually a cutoff. Lung edema, like we just got done talking about, in the case of a shock patient. Oftentimes, they're refractory to oxygen therapy. They're not going to respond. And in the radiographs, or the x-rays, another term for x-rays, radiographs, of this patient, you can see the progression from day 5, day 10, day 13, and day 15. In panel A, upper left, day 5, what I want to bring your attention to is you can appreciate the diaphragm towards the bottom of the thoracic cage. You can appreciate the white outline of the heart, and the lungs show up nice and dark. There's a little bit of clouding that you're seeing laterally in both sides, the right and the left lung. As you move over to day 10, you can see that cloudiness, the lung is no longer as dark or as black as it was looking before. And day 13 is probably the greatest progression of the disease that I can see from these radiographs. And you can see and appreciate, if you go back and forth with your eyes from day 5 to day 13, look at the outline of the lung. There is a whiteout that you see within the lung tissue, and that's because of the edema, the fluid that's pooling within the lungs. Looks like it's starting to resolve at some level at day 15, so I would imagine this patient is having treatment. By day 13, I'm sure they were extremely symptomatic and probably decided to seek treatment. So I don't have information from these radiographs if treatment happened at day 13 or day 14, but judging by the difference in the imaging from day 13 to day 15, it does appear that the patient's getting better. Largest cause of ARDS, pneumonia. Upper image, you can see a scanning electron micrograph of pneumonia. The cells, you can see hematoxylin eosin stained lung tissue. This is a patient with pneumonia within their lung tissue. What is pneumonia? Pneumonia is an infection of the lung. Infection of lung parenchyma. What is parenchyma? Parenchyma is functional tissue within an organ. So it could be either a bacterial infection, a fungal infection, or a viral infection. Obviously with pneumonia, it's a bacteria. And if you were to categorize these from a community standpoint, the most common typical community transmission is bacterial. A atypical community transmission would be fungal or fungus, the second one on the list. And then virus, a lot of times a virus is going to present itself either directly to the lungs or as a secondary effect. Locations, if we look at the different locations, we can see that there are some different regions with the lung that are primarily affected. Most commonly, we've got the difference between bronchopneumonia. I'm looking at the upper image on the slide, the schematic or the cartoon drawing. Bronchopneumonia on the left, lobar pneumonia on the right. And with bronchopneumonia, it is streptococcal pneumonia that's the most common cause. Pardon me, the lobular pneumonia on the upper right, streptococcal pneumonia is the most common cause. And with bronchial pneumonia, you tend to see a gray hepatization that's associated with bronchial pneumonia. In contrast with lobar pneumonia, on the red hepatization that takes place, it's more diffuse. Okay, so you have more focal punctal areas of the lobes with bronchial pneumonia, and on lobar pneumonia on the far right, you get a more diffuse issue associated, and the red appearance is reflecting the microscopic congestion and the hemorrhage that's taking place within the lungs. So two distinct locations throughout the lung, a gray hepatization process and a red hepatization process, gray being associated with bronchial pneumonia, more focal lesions, and red hepatization more associated with lobar pneumonia, and it's more diffuse. You get a microscopic congestion and hemorrhage that's associated with that. At the alveoli level, you can see on the lower image, this is a hematoxylin eosin stained section, the left half of this image, the alveoli are filled with a neutrophilic exudate. And you can see that it's highly, highly congested. And the nice thing about this slide is right down the middle is the border, because on the far right side of that hematoxylin eosin stained histology slide, on that lower image, you can see that there is a nice aerated appearance of the lung. The alveoli are more open, there's spaces in between, and so what you're seeing is the difference between a neutrophilic exudate on the far left and a nice open, normal alveolar appearance, an aerated appearance on the far right. And so that would be sort of a division within the extent of the pneumonia that is causing this affection within the lung. Okay? Okay? So we've got community-acquired, acute, most commonly is bacteria. Atypical is fungus, but it does happen. And nosocomial is usually a gram-negative situation. That's also referred to as hospital-acquired pneumonia. So that's what that nosocomial pneumonia is. Chronic pneumonia, another type that is long-term in nature, obviously because of the terminology of chronic. There are many other types of pneumonia. Again, most commonly we see that pneumonia is associated with bacteria. Okay, application time for this lecture. What I would like you to do is either team up with your class partner or your study partner. And person A, you can do this activity on your own. I think it's more advantageous if you take the time to do it with a study partner. Person A is going to define the major features of emphysema. You're going to draw a picture of an acinus that's normal and contrast it from one that has emphysema for comparison. And then discuss your drawings with your partner. You should be able to explain what's going on with an emphysema patient. Person B, define the major features of chronic bronchitis to your partner. Draw a picture of the normal bronchial tree. Then give an example of one from a patient with chronic bronchitis. So comparing and contrasting normal versus a chronic bronchitis situation in person B, and up in person A, looking at normal versus an emphysema patient with respect to the acinus. This concludes part 2 of 2 of our respiratory lecture. We covered respiratory terminology, respiratory diseases. We only covered 4: atelectasis, obstructive and restrictive pulmonary diseases, as well as some infections that take place. Now, at this point in the lecture, we are done. You should have opened 2 separate video files, part 1 respiratory lecture, and this one is part 2 respiratory lecture. And that concludes our respiratory pathology section. Thanks for your time. Take care.